Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. And today you're going to learn about the latest advancements in the treatment for breast cancer, a disease that is estimated to affect 1 in 8 women here in the United States. Our guest today is Dr. Brittney Zimmerman, a medical breast oncologist with the Northwell Health Cancer Institute Eastern Region. Dr. Zimmerman, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.
Thank you so much for having me. I'm very excited to be here.
Nice to have you. So tell us a little bit about yourself and what made you want to become an oncologist.
Sure. So I'm local to Long Island. I grew up here. My dad was an engineer, so I've always been interested in science. And I came from a big family. I had 5 sisters, so I've always been interested in women's health. When I was doing my undergrad training at Cornell, they actually had a program called the Urban Semester Program, which was basically a semester abroad, but in New York City. And I was able to spend a semester shadowing different physicians at New York Presbyterian Hospital. So that's where I was really exposed to breast oncology for the first time. I was able to shadow for about 6 months of breast oncologist in Manhattan.
Very interesting. What type of screening do you recommend for patients that are coming in and wanting to know whether or not they have breast cancer? And when do you encourage it to start?
Sure. So that's a really good question. We know that breast cancer is extremely common in women. It affects up to 1 in 8 women, about a 12.5% lifetime risk for developing breast cancer. So there are many different guidelines out there, but in general, we recommend starting screening with mammograms at age 40 and screening every year. So there are different types of imaging that can be used. Mammogram is the most typical, but for women who have dense breasts, we can also add in breast ultrasounds. And for women who have even higher risk of developing breast cancer, for example, if you have a family history of a BRCA mutation or a personal history of BRCA, then we add in breast MRI for even greater screening.
So talk to me about those that are more predisposed to cancer. Who are those individuals?
So we know that patients who have a personal history of breast cancer, first of all, are more likely to develop a second breast cancer in their life. So if you've had a history of breast cancer, you should make sure that you're keeping up with your screening. We also know that patients who have a family history, so a first-degree relative with breast cancer, or multiple family members, first and second-degree relatives, then those patients should have screening about 10 years earlier than the relative when they were at their youngest age. So if your sister had breast cancer at age 45, then you should actually start screening at age 35 with mammograms. Mm-hmm. So it really depends on how many people in your family have been affected, what age they were affected at, and your personal history as well.
So if you're very, very predisposed to having cancer and you do the screening 10 years earlier, what else besides the mammogram would you probably see or anticipate doing to diagnose cancer?
So we recommend that those patients, especially with a strong family history, have a clinical breast exam every year. So a breast exam with their primary care physician or their OB/GYN. And those patients should be going for annual screening as recommended, and then adding in the ultrasound or MRI, depending on their level of risk. And there are different calculators that your doctors can use to calculate your lifetime risk of developing breast cancer. So typically, we consider if you have over a 20% lifetime risk of developing breast cancer, that's a high risk and you should be screened more carefully. And we know that screening helps to reduce the risk of death from breast cancer, about 20% using screening mammograms.
Have you, in your career, done a prophylactic mastectomy for those that are very high risk breast cancer patients?
I am a breast medical oncologist. I don't actually perform surgery. That would be for the breast surgeon. And usually this is very complicated for patients because there are so many different doctors who are involved in taking care of a patient who has breast cancer or who is at high risk for breast cancer. But patients often come to see me to discuss their high risk for breast cancer, a family member who has BRCA, or they have BRCA themselves, or some of the other breast cancer related genes. And I will refer them to a breast surgeon for prophylactic mastectomy if they have a sufficient level of risk. But if that's not something that they're interested in, then we just really follow them closely with imaging and clinical breast exams.
So you mentioned the word BRCA. Can you go into a little bit more depth of what BRCA is?
Yeah, so BRCA is a genetic mutation that runs in families, and it leads to a very high risk of developing breast and ovarian cancer during a patient's lifetime. So for a patient with a BRCA mutation, they may have up to 80% lifetime risk of getting breast cancer. So those patients, we often encourage them to have a prophylactic bilateral, mastectomy on both sides, removing all the breast tissue possible. And the BRCA gene itself, it causes a problem with repairing DNA. So those patients are unable to repair their DNA when it gets damaged, and that's why it leads to these cancer cells developing. And it's also important to know that patients with BRCA or these other mutations are not only at risk for breast and ovarian cancer, but also other types of cancer as well, like pancreatic, prostate, melanoma. So they really should be following with a medical oncologist to be screening for all of these different things.
And so if I'm highly predisposed to breast cancer, should I be mentioning this term to my physician in terms of them looking at the BRCA gene, if you will?
Yes. So any patient who has developed breast cancer at this point, we offer genetic screening to all of those patients. If you don't yet have a diagnosis of breast cancer, but you have a very strong family history, then you may be eligible depending on your family history. So your doctor will have to, speak with the insurance companies and look at your level of risk in these calculators and decide if you're eligible for that type of screening.
And what is it, the BRCA? Is it a blood test that I'm doing?
So they can do saliva or blood testing now.
And which is more, I would say, reliable?
They're equally reliable.
They're equally reliable.
Yeah. We tend to do more blood testing nowadays, but it doesn't really matter which way you do the testing.
So what if, I know you said mammography would that be considered the gold standard for diagnosing breast cancer?
Yeah, so mammography is the gold standard. We do add in ultrasounds for many women because a lot of women do have dense breast tissue. And so it's more difficult to pick up abnormalities on the mammogram. But we usually start with the mammogram. And often at the imaging centers, they can add the ultrasound on the same day if they notice that your breasts are dense on the mammogram. And if they see an abnormality, they often do a biopsy at the same time.
And the biopsy,
to try to expedite everything.
I'm sorry. And the biopsy is with a needle.
Yes.
How do you biopsy tissue that is probably suspect to be malignant?
When you're at the imaging center, they usually would have you lay face down on the table and they let the breast sort of drop into its natural position. And then using the imaging, they will numb up the area and go in with a needle and take a sample of the area that looks abnormal.
Okay. And that sample, you look under a microscope and then you're able to really see possibly if it's malignant cells or cells are benign. And so because the mammography is considered a gold standard, what would you say to those individuals who have a fear of getting the mammography?
So it's very understandable. A lot of women are very nervous about getting the screening done. What's great about breast cancer screening is that it's relatively simple. It often picks up breast cancers that are very, very early and that can be treated in a more simple way. And the alternative to not screening is that patients can develop much more advanced breast cancers, and those are much more difficult to treat. So we always encourage patients, to try to overcome that fear if possible, talk to other women who have had the screening done. And, there is the risk of a false positive, and a lot of people are worried about that. But there have been very large studies that show that the benefits of doing the screening outweigh those risks.
You're listening to Your Family's Health on the voice of Nassau Community College 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about the latest advancements in the treatment for breast cancer, a disease that estimated to affect 1 in 8 women here in the United States. Our guest today is Dr. Brittney Zimmerman, a medical breast oncologist with Northwell Health Cancer Institute's Eastern Region. Dr. Zimmerman, just another question. You spoke about self-breast examination, and I know that that is very important, particularly for the woman or man to examine their own breasts. When should you examine your breasts, and what areas of the breast should you include in your exam, and how do you do it?
Yeah, so you brought up a really good point. I just want to highlight it because breast cancer does also affect men. About 1 in every 100 cases of breast cancer is diagnosed in a male. So men should also be on the lookout for any abnormalities in their breast. We don't want self-breast exams to replace the screening imaging because we know that that's really the gold standard. But women should be doing a self-breast exam in the shower about once a month, sort of at the same time of their cycle each month. And the way that we recommend is really to use 2 fingers and kind of go in a circular motion from the outside of the breast in towards the nipple and try to cover all of the breast tissue, and then also underneath the armpits to do the full breast exam. But the main thing is that if you're doing this type of exam once a month, then it will be much easier for you to pick up if an abnormality starts to develop in the breast. And you don't have to be an expert at this exam for it to still be helpful. We do see a lot of women who pick up breast cancers themselves without imaging.
That's very interesting that women come in having felt something that was unusual. And I guess the bottom line is get to know your breasts. Exactly. Particularly, as you are doing breast self-examination, and you are to do it once every month. Is that the same for men?
So we don't have clear guidelines on recommendations for men. For men, often the way that they present with breast cancer is that they just notice that something is abnormal in the breast because there's a lot less breast tissue. So it's kind of easier to see when there's an abnormality. And that's why breast cancer is so much less common in men, because there's just less breast tissue and less estrogen. So for men, we just say the same thing. Be familiar with what your breasts are like normally and keep an eye on them.
Are there any kind of lifestyle changes that I can make to reduce my chances of getting breast cancer?
Yes. So we can attribute about 30% of breast cancers to environmental or lifestyle factors. So it is important to try to modify what we can, although obviously there are cases where that the cancer can't be prevented. So some of the things that we can do and that we know is that breast cancer is more common in patients who are overweight and who have an unhealthy diet. So we recommend staying at a healthy weight, so a body mass index of less than 25. And in order to do that, we recommend a Mediterranean diet, so a diet that is high in fruits and vegetables, fish, olive oil, not our Western diet. So we recommend following a Mediterranean diet and also exercising 30 minutes, 5 days a week. In terms of other lifestyle changes, obviously we recommend limiting alcohol intake and to not smoke at all.
Wow. So that means for some people, really dramatic lifestyle changes to reduce your chances of breast cancer. Are there any major breakthroughs with the treatment of breast cancer? I know we talked about some of the new cutting edge things that are now being done for breast cancer. Talk to about that.
So it's been so interesting. Since I did that urban semester program, that was probably 13 years ago. The field of breast oncology and medical oncology in general has changed so much. We really focus on individualizing care much more now than we did a decade ago. And there are different tests that we can do to look at the genetics of the tumor itself under the microscope to help figure out the best treatment for each patient. So one of the major breakthroughs over the past 10, 15 years has been that development of something that we call an oncotype test. So for patients who have hormone positive breast cancers, one of the different subtypes of breast cancer, they can use this test to help about 70% of patients avoid chemotherapy. So a lot of patients who used to get chemotherapy in the past, now we realize that it's actually not improving their survival, and they don't need to receive that medication with all of those other side effects. So we're really sparing a lot of patients those adverse effects from the chemotherapy. And I think that's probably been the biggest breakthrough for breast cancer over the past 15 years.
That's very interesting. So that leads me to the question, are there different types of breast cancer? And what do we need to know about the different types?
Yes, so that's a really good question.
That's a loaded question.
One of the things that I notice in clinic a lot is that patients come in and they expect the exact same treatment that their neighbor or their friend got when they were diagnosed with breast cancer. But there are many different types of breast cancer. There are 3 different receptors that can sit on the surface of the breast cancer cell: the estrogen receptor, the progesterone receptor, and the HER2 protein. And depending on which of those are positive or negative, you can have a variety of different types of breast cancer. And these are all treated very, very differently. And breast cancer treatment also depends a lot on the stage of the breast cancer when it presents. So whether it's localized just to the breast or whether it involves the lymph nodes or other organs throughout the body. So we really look at the subtype of breast cancer in terms of those receptors. And then we look at the stage of the cancer. And then we look at the patient themselves and their other medical problems, because not every patient can be treated the same. We add on top of that the genetic information from the tumor. And so it's really a very complicated decision when you're coming up with a treatment plan for a specific patient.
And therein lies you, the medical oncologist, that's able to look at all of these variations and come up with how I'm going to treat the patient. You mentioned chemotherapy. What is that? And what is radiation?
Chemotherapy is a medication that's given through an IV. And the goal of that medication is really to kill cells that are rapidly dividing. And those would be those cancer cells. So the traditional chemotherapy that we have been using for many, many years has not changed all that much, but the way that we support patients through the chemotherapy has improved a lot. So patients are often very nervous about getting chemotherapy, but there are so many things that we can do to help prevent them from having, symptoms like nausea, vomiting, and
loss of hair. That's a big deal.
Exactly. So one of the things that we can offer now for certain chemotherapy regimens is the cold cap, which is basically a cold cap that you place on your head for several hours during the treatment. And it helps to constrict the blood vessels in the scalp and prevent the chemo from going to those hair follicles. And so it helps to prevent hair loss for about 60% of patients for that specific chemotherapy regimen. Radiation is used really to prevent a local recurrence, and that's actually given by a different type of doctor, a radiation oncologist. And usually that consists of about 20 sessions, very short, like 5 to 10 minute sessions of radiation directed at the area where the cancer was removed to prevent the cancer from coming back locally.
So you may have one, or you may have both, or, how does that work?
Yeah, so it really is looked at on a case-by-case basis. And it depends on the type of surgery that you decide to have. So if you have a lumpectomy, which means they just remove the cancer and a little bit of the area around it, then we typically recommend radiation as well. And in terms of outcomes, that would be equivalent to if you had a mastectomy where you remove the whole breast and then you may not need radiation. What we do a lot in the field of oncology is what we call tumor boards. So we get together. Now everything is pretty much virtual. And which is nice because it can bring people together across the whole system from whatever cancer system you're in. And we usually have the medical oncologist, the radiation oncologist, the breast surgeon, the pathologist, the radiologist, all together on the same conversation, going through the patient's entire case. And that's how we really, determine the best treatment plan for each patient.
It's actually a very comprehensive, collaborative approach. You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about the latest advancements in the treatment for breast cancer, a disease that is estimated to affect 1 in 8 women here in the United States. Our guest today is Dr. Brittney Zimmerman, a medical breast oncologist with Northwell Health Cancer Institute's Eastern Region. So, Dr. Zimmerman, let's dispel some of the myths that are out there. And one that I can think of is if you use hair dye or you use any kind of dye, that would increase your predisposition for breast cancer. Is it true or false?
So there's no concrete data that is related to development of breast cancer. So I would say false for that one.
How about eating a lot of dairy? Does that
False as well.
Okay, I give you another one. How does breastfeeding, if I have cancer of the breast, can I still breastfeed?
That's a really interesting and important question. So first of all, breastfeeding decreases your risk of developing breast cancer. So for every 12 months of breastfeeding that you do, your relative risk of getting breast cancer decreases by about 4%. So we actually encourage breastfeeding. The difficulty with breastfeeding after breast cancer is for a lot of patients, we remove a lot of the breast tissue, which makes it more difficult. And a lot of patients who have hormone positive breast cancers need to be put on anti-estrogen medications for many years, which are not safe with breastfeeding. So there can be a lot of challenges with that, but depending on how far, the age that you're diagnosed and how far it's been since your diagnosis, those are conversations to have with your medical oncologist. And one of the other issues that comes up is fertility, because we're seeing breast cancer in younger and younger women.
Yeah.
And some of these women want to have future childbearing. So we always recommend that patients go for a fertility evaluation and consultation before they start, chemotherapy, because with the chemotherapy, they may go into a menopause. So we want them to retrieve eggs if they're interested in having children in the future before we get started with that treatment.
Very interesting. So how about another myth, if I traumatize my breasts, maybe a car accident where I had a bad bump or trauma, can that increase my predisposition for breast cancer? That
doesn't tend to really increase your risk of breast cancer, no.
Okay, I'll give you one more. What if on my father's side, okay, not my mother's side, does it matter whether it's maternal breast cancer that runs in my family or maternal breast cancer, my mother or father, that increases my predisposition for breast cancer?
It doesn't matter, but if you have a male in the family who has breast cancer, the chance that they carry some sort of genetic mutation is much higher. So I would say that any male with breast cancer needs genetic testing. And once you have the results of their genetic testing, that will impact whether you need genetic testing.
So once I'm diagnosed with breast cancer, it is sounds like a daunting road between the treatment of chemotherapy and or radiation. How can I still enjoy life? I'm thinking about my sexuality. I'm thinking about my relationship, my intimacy with my partner. How do I, engage in life?
So one of the most important things is to have a very close, good relationship with your medical oncologist. There are a lot of resources dedicated to patients with breast cancer, which is really fortunate because, it's so prevalent and there's so much money and resources put towards the research for breast cancer. So it's for a lot of these bigger health systems, there's often a breast cancer navigator who will get involved and really help patients to coordinate, especially in that beginning period where they need to be linked up with a breast oncologist, a radiation oncologist, a breast surgeon, and they're just totally overwhelmed. So having some sort of navigator is really helpful. We also often have social workers at the breast cancer clinics, and they can help patients apply for financial services. There's a lot of grants that are available to help patients with the financial burden of being diagnosed with breast cancer, as well as nutritional counseling to help patients with dietary changes. In terms of sexuality, we do find that with some of the anti-estrogen medications that we prescribe, patients can develop vaginal dryness and other issues like that can impact sexual function. So we have many different non-hormonal vaginal lubricants that we can prescribe. But the most important thing is to just be having an open conversation with your medical oncologist, because patients will often self-discontinue their anti-estrogen medications because they're embarrassed to have these conversations with their doctor. So our goal is really to avoid that and to make sure that we're addressing any of these lifestyle issues that come up because of the treatments that we're recommending.
So what has been your youngest and your oldest patient, if you will, that has been diagnosed with breast cancer?
Right now, I have several patients in their 30s diagnosed with breast cancer right now.
Oh.
I know you can see it in your 20s as well. But most of these patients actually don't have a family history, and it's really just a sporadic, random cancer development. And those younger patients tend to just pick it up on their own exam. In terms of older patients, we see patients well into their 90s, and these patients tend to do very well. They can go on anti-estrogen therapy, and it usually has very little impact on them because their estrogen is already pretty low once they're at an older age. So those patients tend to do very well.
So as we age, is the expectation that I am going to get cancer increase with age? Would you say that?
Yeah. So breast cancer risk increases with age, definitely. And we know that the screening for breast cancer is most effective as you get into the 50, 60, 70 age group. But we are seeing younger and younger patients with breast cancer, and that's why we recommend starting imaging at age 40.
So you talked about social support, and you mentioned social work. Are there any kind of support groups that would support women and men who have breast cancer going into treatment or post-treatment?
Definitely. So a lot of these support groups are now virtual online, which I think people actually find very helpful because it's a decreased time commitment. A lot of patients don't feel up to going to an in-person support group. But the most important thing is to link up with the social worker at whatever clinic you're being treated at, because the different support groups depend on the area that you're in. And sometimes they depend on where you are in your cancer treatment journey. So it's really very specific to each patient where they're at and what kind of support they need.
If you had one or two words to wrap all of this up, Dr. Zimmerman, what would you say to your listeners?
Don't be afraid to get screened, and that we're here for you if you need us.
Thank you so very much for a most informative session and just letting us know about breast cancer. Thank you for being here, Dr. Brittney Zimmerman, a medical breast oncologist with Northwell Health Cancer Institute Eastern Region. We hope you stay safe and continue to stay healthy and continue to do the great work that you're doing.
Thank you.
This is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College, and we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the nursing department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.